Boa tarde a todos. Vamos iniciar agora o bloco 9, tratamento percutâneo do câncer de mama. Teremos a apresentação da Mhairi Mactier sobre análise comparativa das abordagens percutâneas, crioterapia versus VAE versus ablação por radiofrequência. Mhairi Mactier é pesquisadora clínica da Universidade de Glasgow. E, na sequência, teremos compreendendo as experiências dos pacientes para informar estudos futuros e otimizar personalização do tratamento do câncer de mama inicial, com Shelley Potter, que é professora de Oncologia Cirúrgica e Ciências Translacionais da Saúde da Bristol Medical School. Posteriormente, teremos omissão da radioterapia pós-operatória em pacientes selecionados com câncer de mama inicial após a ressonância magnética pré-operatória, PROSPECT, com o professor Bruce Mann, que é professor de cirurgia na Universidade de Melbourne e diretor da unidade de mama do Victorian Comprehensive Cancer Center. Por favor, a primeira palestra.
Good morning, afternoon or evening, wherever you are in the world. My name is Mhairi Mactier and I'm a General Surgeon and Clinical Research Fellow from Glasgow in Scotland. Thank you for the invitation to talk today. I have been given the title Comparative Analysis of Percutaneous Approaches, Cryoablation versus Vacuum-Assisted Excision versus Radiofrequency Ablation. I'm going to present to you the existing evidence and ongoing clinical trials for each technique and then discuss some comparisons between these techniques. So why are minimally invasive techniques important? Well, we know that breast cancer screening disproportionately detects early good prognosis breast cancer, which has a significant treatment burden for our patients and associated health cost implications. Emerging evidence suggests a role for minimally invasive techniques in the management of these patients, which enables many women to avoid surgical interventions. We know this is important to and accepted by our patients from the UK James Lind Alliance in 2020 in a recent patient survey, where 20.6% of patients wish to omit surgery if considered safe to do so, describing this treatment as disfiguring with the greatest long-term effects, particularly psychologically. And Professor Potter is going to talk to you a bit more about this next. Moving on to our different techniques, vacuum-assisted excision was developed from vacuum-assisted biopsy, or VAB. Using a large needle, multiple cores are taken on a single pass. A larger volume of tissue taken allows for histopathology of the entire mass, which provides additional information to FNA or core biopsy. The technique is performed under X-ray or ultrasound guidance, under local anaesthetic in the outpatient setting. And perhaps most importantly, this technique is acceptable to our patients. In a survey of 189 women, 90% of women preferred VAB to open surgical biopsy, as it was less time consuming and provided better cosmetic results. VAE is embedded in clinical practice for the management of benign and indeterminated B3 lesions, and this is supported by the UK NICE guidelines, the European guidelines and the National Cancer Network. However, use of VAE for in situ or invasive disease is not routine practice. A retrospective analysis of 116 lesions has demonstrated feasibility of VAE in early breast cancer amongst a select group of patients. Patients diagnosed using VAB who underwent subsequent open surgical resection were analysed. Patients with no or less than 3 mm of residual disease after VAB were considered potentially suitable for percutaneous resection. They identified low or intermediate grade tumours, less than 10 mm in size, were potentially suitable for this technique, enabling avoidance of surgical intervention. And further prospective trials are required to consolidate these findings. The ongoing UK small trial is a prospective randomised 2-to-1 phase 3 trial assessing VAE versus open surgery in patients with small, biologically favourable screen-detected breast cancers. In the VAE arm, a clip is placed at the tumour bed and completeness of excision is assessed radiologically. Any patients found to have residual radiological disease or grade 3 pathology will be offered open surgical excision. All patients will have adjuvant radiotherapy to the breast and endocrine therapy as per local protocols, with mammographic follow-up of 5 years. So the only change would be the form of surgical resection. Co-primary outcomes of this study are non-inferiority rates of VAE in avoiding a secondary procedure to achieve complete resection, and local recurrence rates at 5 years. Secondary outcomes include psychological and aesthetic impact, as well as healthcare economic analysis. The small trial is currently in recruitment and expected to close in June 2025, so act fast if you want to get involved. And I was unable to identify any further worldwide randomised controlled trials exploring the use of VAE in early breast cancer. Cryoablation uses cytotoxic effects of cold to create tumour necrosis. There are 3 phases: the first freeze, passive thawing, and the second freeze. Freezing causes intracellular osmolarity and cellular dehydration, whilst passive thawing causes cellular swelling and subsequent rupture. The second freeze is required to enhance the damaging effects of cold and expand the area of tumour necrosis, creating an ice ball extending at least 1 centimetre beyond the tumour margin. The procedure can be performed under ultrasound, CT or MRI guidance using local anaesthetic. It typically requires less local anaesthetic than other minimally invasive treatments due to the synergistic cooling effects of the probe. It is performed in the outpatient setting and takes less than 45 minutes to complete. The ablation area is limited due to concerns of fat necrosis and/or infection, and other minor side effects include seroma, skin retraction, and skin necrosis. However, in a systematic review of 161 patients, 99% of patients reported satisfactory cosmesis, and this technique is acceptable to our patients. Use of cryotherapy in benign breast lesions and metastatic deposits is well described. The ACO-SOG Z1072 trial was the first substantive trial to demonstrate the use of cryoablation in the treatment of primary early breast cancer. Patients with unifocal disease less than or equal to 2 centimetres underwent cryoablation followed by surgical resection within 28 days. 87 cancers were treated, with ablation of the target lesion successful in 92% of patients. However, 24.1% of patients had residual in situ or invasive disease. The trialists attributed this to multifocal disease out with the targeted cryoablation zone, and they advised that better patient selection is required for consideration of cryoablation in early breast cancer. So then along came the ICE3 trial. So this trial, the cryoablation of low-risk small breast cancer trial, has very recently published their 5-year follow-up results. It was carried out in the US, and women over the age of 60 with low-risk breast cancer underwent cryoablation with a follow-up ultrasound core biopsy at 6 months to confirm absence of residual viable disease. The study had 194 participants with a median follow-up of 54 months. And they found ipsilateral breast tumour recurrence rate of 4.3% at 5 years with breast cancer survival of 96.7%. So pretty good results. They reported no serious device-related adverse effects and a relatively high proportion of minor adverse effects at 88.2% and moderate adverse effects at 9.6%, but all resolved without long-lasting effect. There was 100% cosmetic satisfaction at 5 years and a significant improvement in patient distress at 6 months compared to baseline. Ongoing clinical trials include the FROST trial, another US trial which is similar in setup to the ICE3 trial, the main difference being that they include women over the age of 50 and they carry out follow-up using mammography, ultrasound and MRI. So hopefully this trial is able to answer the important question for us of what is the best way to follow up these patients radiologically. This trial is close to recruitment and in the follow-up phase, so results should be coming very shortly. Now, of note, both the ICE3 and FROST trial are single-arm phase 2 studies, and there are currently no randomised controlled trials exploring the use of cryotherapy in early breast cancer. Last but not least, radiofrequency ablation. So this technique uses low-frequency radio waves with long wavelength to generate heat around a needle electrode, causing localised coagulative tissue necrosis. Cancer cells contain more water than normal cells with a very fragile neoplastic vasculature, and they're more susceptible to heat-induced thrombosis, resulting in localised necrosis of malignant tissue with minimal effect on the surrounding healthy cells. So RFA can be performed under ultrasound, CT or MRI guidance, with ablation observed using the formation of echogenic microbubbles. The technique is performed under local anaesthetic and in the outpatient setting. Similar to cryotherapy, the treatment goal is to ablate the whole lesion plus a 1 centimetre tissue rim. So that reduces its suitability for lesions close to the skin, nipple, chest wall or implant. Heat is not supplied by the probe itself, therefore a limited volume of tissue can be ablated at once. Additional reported side effects include skin burns, breast inflammation, nipple retraction and pneumothorax. RFA is used for both treatment and palliation in numerous solid tumours, including hepatocellular carcinoma, non-small cell lung cancer and renal neoplasms. Technical success for RFA in the treatment of breast cancer was first described in 1999, and there have been multiple studies since then. Evidence suggests that RFA is best used for smaller lesions less than 2 centimetres. So in a retrospective analysis of 386 patients who underwent RFA, they found that there were higher local recurrence rates and reduced disease-free survival in patients with tumour size greater than 2 centimetres compared to those with a tumour less than 2 centimetres. These results were supported by the results from a meta-analysis of 401 lesions, where they found 96% complete ablation rate in tumours under 2 centimetres, and there was a high patient tolerance of 98.4%. These results led on to the phase 3 multi-centre Raffaello trial, so radiofrequency ablation therapy for early breast cancer as local therapy, which has very recently shared their 5-year follow-up results. So this was a prospective multi-centre single-arm study assessing the safety and efficacy of RFA in early stage breast cancer. They took patients with unifocal breast cancer under 1.5 centimetres who underwent RFA and sentinel lymph node biopsy under general anaesthetic. Following adjuvant whole breast radiotherapy, patients had follow-up imaging and a VAB at 3 months. Any evidence of histological residual lesions, then patients were offered an open surgical resection. The primary endpoint was 5-year ipsilateral disease-free survival, and the results found that this was 98.6%, with skin burns reported in less than 2% and no severe device-related adverse effects. So overall, these results are pretty good, and this is the largest prospective trial to date. But we do have to acknowledge that these patients underwent treatment under general anaesthetic, and we don't know if the same results would happen if we carried out the procedure under local anaesthetic. And I was unable to identify any randomised controlled trials exploring RFA in early breast cancer. Now moving on to comparing our different techniques, this summary table demonstrates each technique, how it works, what kind of radiological guidance is used, and what our patients think of the technique, as well as some other important factors. So VAE will excise the tumour, whilst both percutaneous ablation techniques leave a mass in situ. This may be difficult for patients, particularly those with palpable lesions, who will continue to complain of a lump, but also poses challenges for clinical and radiological follow-up. In addition, none of our techniques allow for assessment of surgical margins, a topic of conversation which could make for a whole conference in itself, but I thought it was an important thing to mention here. Here we have a summary table of the existing evidence and ongoing trials for each technique. So for VAE, we have the ongoing small trial. For cryoablation, we have results from the ACOSOG Z1072 trial, the ICE3 trial, and we patiently wait for results from the FROST trial. And for RFA, we have our Raffaello trial. So looking for trials which compare different techniques, I found the Thermac trial. So this trial compared efficacy of radiofrequency ablation, microwaves and cryoablation for early stage breast cancer with the goal of selecting a technique for a subsequent phase 3 comparative trial. They recently presented their results at USOBI conference in October 2024. So patients with early breast cancer less than 2 centimetres underwent radiofrequency ablation or microwaves or cryoablation, followed by open surgical resection and sentinel lymph node biopsy at 3 months. And the primary outcome was complete ablation rate. They found there was a complete ablation rate of 94% with no adverse effects amongst patients undergoing cryoablation. And this technique was preferred as it was considered the least painful technique. In comparison, patients from the same study who underwent radiofrequency, the complete ablation rate was only 33% and 50% of patients experienced mild to moderate adverse effects. So their next steps would be to take cryoablation forward to a phase 3 trial. I found no evidence of trials comparing percutaneous ablation techniques and VAE. So in conclusion, percutaneous approaches or minimally invasive techniques may offer a suitable alternative to surgical excision for low-risk early breast cancer. But one size doesn't fit all. All clinical decisions should be made on an individual patient basis. High-quality evidence from prospective studies, including RCTs, are required before adopting these techniques in routine clinical practice.
Thank you very much for this opportunity to talk about our international patient survey, which aimed to understand patients' experiences of breast cancer treatment to inform future de-escalation trials. So as we all know, breast cancer treatment is multimodal. It involves a combination of surgery, radiotherapy, chemotherapy, hormone treatment, and other targeted therapies. But as our understanding of breast cancer treatment has evolved, it's become clear that not all patients benefit from all treatments. It's also clear that although not all patients will benefit, they will almost all experience potentially avoidable harms from treatments they simply don't need. We need to move away from a one-size-fits-all approach to breast cancer treatment to a more tailored, personalised approach. But it's really important that we involve patients in designing these studies, and we develop and design trials that address questions that are important to patients and also address their concerns. So the aim of our international patient survey was to understand the experiences of patients who'd had treatment for early breast cancer to inform decision-making about future risk-adapted studies. So this was an international online survey developed in collaboration with patient advocates that was open for a 5-month period between April and August 2023. It covered simple demographics, including age and geographical location, the treatments that patients had received for their breast cancer, views about omitting treatments if it was safe to do so, and other comments they might have about future studies that may look at reducing breast cancer treatments in general. We circulated the survey via social media and via our patient advocacy networks with a view to try and get international patient engagement with this work. 235 women with lived experience of early breast cancer completed the survey. Approximately 2/3 of women were between 40 and 60 at the age of diagnosis, and over half were from the UK, although we aimed to get representation from North America and Europe as well as part of the survey. When we asked patients what treatments they'd received, 90% of patients had undergone surgery for their breast cancer, 2/3 had endocrine therapy, approximately 60% had chemotherapy, and a slightly larger proportion had radiotherapy, with other treatments less frequently represented. Of the 234 women, 194, so 83%, selected a treatment that they would like to avoid if it was safe to do so. And the results were somewhat surprising. Over a third would like to avoid chemotherapy if it was safe. Approximately a third wanted to avoid endocrine therapy. Just over 20% would like to avoid surgery. And although there are large numbers of ongoing studies focused on de-escalating aspects of radiotherapy, only 10% of respondents wished to de-escalate radiotherapy if it was safe, with just 2% choosing other treatments. So why? Why are patients suggesting they would like to avoid these treatments if possible? So in terms of chemotherapy, it was described as a brutal, barbaric and harsh treatment that was psychologically and physically very challenging, with patients becoming scared that they might become seriously unwell. It impacted all aspects of their family life and daily activities and stopped them from working. They particularly highlighted hair loss as distressing, mostly because it meant they lost their identity and visibly identified them as being a cancer patient. Some patients also highlighted long-term effects of complications such as neuropathy on quality of life, as it prevented them doing hobbies and activities they'd previously enjoyed. And this quote is an example of one of the ones in the survey. Chemo was by far the worst part of my treatment. Awful side effects, hair loss, requires a long recovery period, and many quotes were very similar to this. Just under a third of women wished to de-escalate their endocrine therapy, and this was because of the profound impact of the side effects on all aspects of their quality of life. This included joint aches, fatigue and sleep disturbance, hair loss and loss of libido. And some women commented that taking a tablet was a daily reminder of their cancer diagnosis. This lady said, "Taking this for 5 to 10 years is hard on the joints and bones. You have no sex life. It's a constant reminder you've had cancer." And this patient said, "Endocrine therapy seems like a 10-year sentence, which makes every day miserable. I'm existing, not living." So these are really quite profound statements about the impact of endocrine therapy that I think many of us think is fairly straightforward for patients when many women struggle. And if we could identify women who wouldn't benefit, this would be significant. 1 in 5 women opted to omit surgery if it was safe. And I think as surgeons, we think surgery is a small aspect of their treatment, but women really painted a very different picture. Surgery was described as impacting body image and having long-term psychological effects, not only on losing a breast, but also on the impact of personal relationships and intimacy. And again, any distortion or poor cosmetic outcome was a constant reminder they'd had breast cancer. The number of operations, recovery and complications were highlighted as challenges. And many women, particularly those having axillary node clearance or mastectomy, felt that potentially their surgery was unnecessary. This patient said, mentally more than physically, her surgery had left her feeling abnormal and half a woman. This lady said that she felt ugly after her mastectomy. It was painful and had affected her sex life. And this patient said that she would have preferred not to have had her lymph nodes removed, as it would be great to know whether they had cancer without such extensive surgery. Omission of radiotherapy was less frequently identified, and this was mostly due to short and long-term side effects, logistical issues, and the psychological impact of treatment. And although radiotherapy traditionally has been a course of 5 weeks, 3 weeks, more recent improvements in ultra-hyperfractionation, meaning that women only have to attend for 5 days, really make radiotherapy less of an issue for many women. These quotes highlight the issues that some women have with radiotherapy. The first patient said, "My reason for choosing radiotherapy was logistics. It took me 30 minutes, a 30-minute train journey and a 15-minute bus ride, and I did that every day for 15 days. Another patient said that she found it uncomfortable and she felt dehumanized by her treatment. But I think these women were very much in the minority. Patients overall were really supportive of a more personalized approach to treatment. This patient summed things up where she said, "We should be giving what can work, not just standard of care. We need to move to more personal therapies. But patients were cautious. The First Lady said, "I'd be totally against reducing treatments, as patients like to feel they have all available treatment to prevent death and spread. If either event occurs and they have not had the benefit of all available treatments, they would be devastated, and I would understandably think the event could be prevented." And another patient really emphasised the importance of high quality research, saying they would only want their treatment reduced if research showed it would not be detrimental to my progress. Other women highlighted that actually it was about communications of risks and benefits to support patients to make more informed decision-making when considering treatment de-escalation or a more personalised treatment approach. So she said patients currently think more is better. But they need to understand perhaps less can be just effective, but this information must be presented in language they understand in order for them to make an educated decision. They may still make the same decision, but the decision will be theirs. And I think this has really illustrated some of the difficulties that surgeons and oncologists have communicating the benefits of less versus more treatment. So in summary, our survey has shown women with breast cancer may wish to optimize different aspects of their cancer treatment. All women are different, they have different preferences and values, and not all patients would choose to avoid the same things. We need to co-design with our patient advocates a portfolio of studies that look at de-escalating or personalising different components of treatment so that patients have a choice about which trials they wish to participate in. But the most important thing is that we need high quality research underpinned by accurate communication of risk to support any change in practice, as patients want to know this is safe, and oncological safety and hard-won gains in breast cancer survival are of paramount importance. Development of studies looking at optimizing chemotherapy and endocrine therapy should be prioritized, as these are the treatments that patients suffer with most and would like to avoid if they could. Because at the end of the day, we want to tailor treatments for our patients so they have long, happy lives, and they not only survive their breast cancer, but they thrive. Thank you very much for listening.
It's a pleasure to join you. Thanks for the opportunity to present our work on the Prospect study. Speaking from Melbourne, Australia, it would be nice to have joined you in person in Brazil. I have no conflicts of interest. This study goes to the question of why it's considered that everyone needs to have adjuvant radiotherapy after breast conserving surgery for invasive cancer. And the background to this is the careful histological work done by Dr. Holland in the 1970s on mastectomy specimens. He showed that there was a substantial incidence of both invasive and pre-invasive disease some distance from the gross edge of the tumour. A number of landmark randomised trials were done. The Lancet reported the overview of these, and what they showed is that after wide excision without radiation, there was a substantial incidence of local recurrence, substantially lower with the use of radiation. As far as breast cancer specific survival is concerned, again, there was a difference. It was a smaller difference and it was delayed, but it was definitely there. Third, this study from Boston, single-arm study of stage 1 patients who underwent wide excision alone, what it showed is a very high rate of local recurrence. The incidence 3.5 per 100 patient years follow-up led to a fairly definitive statement that with the possible exception of elderly patients with comorbid conditions, radiation remains standard. An interesting thing about the study from the Lancet overview is when the mortality is looked at, and keeping in mind this is breast cancer deaths, those patients with low and intermediate risk node negative patients, there's really no difference in mortality. All the difference is in the node positive patients and the node negative patients with a large predicted difference in risk of incidence of recurrence with radiation. left open the question of whether radiation can be de-escalated. And there are two key studies, the ECOG study, known as the Hughes study, and more recently Prime 2, published by Dr. Kunkler. And what these were quite similar: stage 1 ER-positive cancer treated with wide excision without radiation compared to those with radiation. The results were very similar. Those treated without radiation had a 10% incidence of local recurrence at 10 years. Those with radiation, it was more like 2%, but absolutely no difference in overall survival in either trial. As our understanding of breast cancer biology grew, we routinely use the biology of the index cancer to guide endocrine therapy and chemotherapy. So various trials have been done using the same biology to potentially identify patients in whom radiation may be omitted. Lumina Expert, Primetime and Deborah are a few, and there are some others. And last year, the first of these was published. This is the Lumina study from Canada. Luminal A patients with centrally assessed Ki-67 of less than 13.25 and various other factors treated without radiation in a single-arm study, showing that at 5 years the local recurrence rate was 2.3%. No data released about what happened after that, but certainly a very low recurrence rate. It's interesting that none of these trials have, either the past or the current ones, require any breast imaging beyond a mammogram. Now, thinking about that, as it's known that additional disease is frequently found with MRI, implicitly there's an assumption that disease beyond the index is not clinically relevant. This seems a little odd. I think why we accept this goes back to this very influential editorial by Dr. Morrow from 2004, where she was talking about breast MRI, and on the basis of studies showing an increased rate of mastectomy, her comment was that breast cancer patients undergoing MRI should be obliged that this step forward in technology may take them right back to the 70s and result in mastectomy for disease that can be controlled with radiation. And just very recently, the Brazilian team published this nice systematic review of the impact of MRI on surgical outcomes, including the breast MRI study, and their conclusion was, from an RCT perspective, preoperative MRI for newly diagnosed invasive cancer did not improve surgical outcomes, may increase the risk of mastectomy. While I agree that is the analysis of the study, it is interesting that it is confined to, I would say, the surgical outcomes. We had a hypothesis that actually MRI can detect the lesions successfully treated by radiotherapy, and the follow-on from that is that wide excision alone is sufficient for those with low-risk cancer that is unequivocally unifocal on MRI. That led to the Prospect study, which is a 2-arm cohort study using MRI and pathological features to identify patients for radiation emission. This was sponsored and led by the team at Breast Cancer Trials here in Australia. A very simple schema: females with clinical stage 1 cancer that was not triple negative and without LVI or extensive DCIS had preoperative MRI with all BIRADS 3+ lesions biopsied, however, by whatever means. And then those with nil, minimal or mild background enhancement who were pathologically stage 1 with adequate surgical margins and no occult malignancy were managed without radiation, whereas the others had standard management. Importantly, systemic therapy was mandated. For almost all this was endocrine therapy with a small number chemotherapy, and we've got follow-up. The endpoints: the primary endpoint, ipsilateral invasive recurrence rate at 5 years. The expected oncological secondary endpoints. We also analysed the outcomes of Group 2, those who were not eligible for radiation emission on study, did an economic analysis, and we've done some parallel quality of life studies. The results, this is the results of the cohort, largely screen detected patients. Screening in Australia is patients 50 to 75, so as expected, median age of 63. 3/4 had lower mammographic density, nearly 80%. A little over 3/4 had low background enhancement. Importantly, 1/3 of the total cohort did have at least one occult lesion on the imaging, either benign or malignant. 99, so that's about 25% of the whole cohort, were excluded from omission on study due to the background enhancement on MRI. The reason for that, we were concerned that it may mask occult disease. The index cancers in our cohort, low risk but not very low risk. Median tumour size was 12. About 50% were grade 1, well 43% overall grade 1, 52% grade 1 in the radiation emission cohort. Mostly invasive ductal cancer, mostly ER positive, HER2 negative, smaller numbers of grade 3, smaller numbers of HER2 positive. Here's some examples. Here's one of the early patients on study with a unifocal cancer, both on mammogram but clearly on MR. Here's another more complex, quite complex actually. She had that index cancer that was about 15 millimeters. What we found on her ipsilateral, on her MRI, some non-mass enhancement posteriorly, turned out to be DCIS. Probably would have been identified on the surgical pathology, but that additional mass anteriorly was a small occult cancer. Another patient who was excluded for 2 reasons. Got the index lesion there on the right. She's got moderate background enhancement. We couldn't be sure that some of those dots weren't cancer, so that was an exclusion. But she also had an additional cancer on the left that was previously occult. Interesting patient early on, quite very interesting. That index cancer with the fine arrow, the mass behind, surprisingly, was certainly occult on both mammogram and ultrasound. They were both biopsied. The index cancer was grade 1 ER positive, you'd say low risk. The additional lesion was actually grade 2 and ER negative. There weren't many where the pathology of the occult cancer was different, but this is one, and you can imagine what would have happened had this lady been treated with white excision without radiation. So what were the results? I think the key result, and this really is very important, in our whole cohort of 443, we found an additional malignancy and treated it in 11% of the patients. That's 48. There are actually 61 occult lesions. More of them were ipsilateral, but a lot were contralateral. On the ipsilateral side, more was DCIS than invasive cancer. I'm not sure exactly why, whereas contralaterally, most of the additional lesions were invasive cancer. We looked for associations between occult lesions and the imaging. There was no association between age, index cancer size, grade, or cancer type in this group. That's important. If you look at age, the ladies over 70, just as many occult malignancies as others. But the 2 factors that were associated with an increased, with a rate of malignant occult lesions were mammographic density. Those with higher density were more likely to have an occult cancer. However, 8% of those with low density did have one. And background enhancement, double the number, so 18% of those with moderate or marked, as opposed to 9% of those with. This is consistent with some recent reports that background enhancement is associated with an increased rate of local recurrence. So what were the outcomes? Here's the key outcome. 200 patients in group 1. The ipsilateral invasive local recurrence rate at 5 years was 1%, and very few other events. When we looked at the entire cohort, that's all 443, we actually had follow up on almost all of them. You can see we had 2 ipsilateral invasive events. There was a second one at 7.5 years. 1 ipsilateral regional recurrence, 1 regional and distant that I'll come back to, 2 contralateral cancers. And in group 2, there were 3 recurrences, ipsi and 3 contra, but no distant recurrences. We did a health economic analysis for the Australian health system. We showed that participation in the trial led to substantial savings, which means that money saved via emission of radiation was more than offset additional costs. And our quality of life studies that we've separately published showed somewhat counterintuitively less fear of cancer recurrence in those who emitted radiation and better quality of life. So at a median of 5 years, the ipsilateral invasive recurrence rate was very low, supporting our hypothesis and suggesting MR may allow identification of truly localized cancers. It appears to be very cost effective with good quality of life outcomes. I'll come back to this slide, this single case of ipsilateral synchronous regional and distant recurrence. Interesting thing about this was the pathology looked quite different. So we went back and we did whole genome sequencing on a number of cases. Here is the key. The 2 local recurrences, that's number 1 at 4.5 years, number 2 at 7.5 years, these are clearly clonal. These are true local recurrences. But the only distant metastasis was unrelated. This wasn't surprising. It was a lobular cancer 4.5 years after treatment of a ductal cancer. Unusual case, but it means there were no distant recurrences at 5 years in the entire cohort. And all of this, we were very pleased when the Lancet agreed to publish it early this year. So what are the implications? With no distant metastases from the index at a median of 5 years, it does suggest that many patients who are actually cured after surgery may be identifiable, and maybe endocrine therapy can be safely de-escalated or omitted. That's definitely a hypothesis, a lot more needed. Our final analysis is in May of 2026, when the 100th patient reaches 10 years, but we need a truly multi-centre study to confirm and extend these findings and explore selective de-escalation of systemic therapy. And for that, we have Prospective, the international validation experience of Prospect, which will be very similar, but larger, more multi-centre with endocrine therapy not mandated for the lower risk. And that's going through ethics now. We hope to have that open early next year. So is there a new paradigm? Not yet, but maybe. Could be that in very early stage disease, identification and treatment of additional cancer is vital. And it could be that partially treated additional foci do explain many of the subsequent events that we now see. And in the future, we may be able to identify patients who have actually been cured after surgery. What do I think will happen? I think a combination of sensitive imaging with local therapy of all tumour foci, but then tumour phenotyping, analysis of circulating factors will be key to optimised treatment. A lot of people to thank, particularly Alison Rose, the radiologist who read all of the imaging, and Jane Mary Hughes, the trial manager, who made sure we had such remarkable follow-up. Thank you, and I'm very happy to take some questions.
Olá, como vão? É um prazer estar aqui para falar nessa sessão de tratamento percutâneo do câncer de mama e para falar do estudo desenvolvido na rede mama, rede master no Brasil, que é o Vacuum Assisted Excision, excisão assistida a vácuo, uma abordagem única, em tempo único, para o diagnóstico e tratamento de lesões de potencial de malignidade indeterminado e pequenos cânceres de mama, estudo denominado VAE Breast-01. Os conflitos de interesse. Existem várias oportunidades para evitar a cirurgia de mama, especificamente o VAE Breast-01 aborda a oportunidade de evitar cirurgia para lesões B3 e para pequenos carcinomas invasivos e in situ. Existe um racional para isso, e esse racional nós vamos abordar em cada tópico. Excisão assistida a vácuo é um procedimento percutâneo que consegue fornecer um material comparável a pequenas lumpectomias, pequenas setorectomias, pelos vários métodos de imagem disponíveis, deixando apenas uma cicatriz indelével. As lesões de potencial de malignidade incerto, elas representam 5 a 10% das cobiópsias. Como o próprio nome já diz, uma cobiópsia nessa situação é indeterminada pelo risco de upgrade para carcinoma. Esse upgrade ocorre em média de 16 a 20%, mas varia conforme a lesão, saindo de 7,5% na cicatriz radial sem atipia a 35% nos papilomas com atipia. A excisão assistida a vácuo é um método já consolidado como uma alternativa à cirurgia para as lesões B3 sem atipias, para as lesões, algumas lesões com atipia, como a neoplasia lobular, a atipia arterial plana e a cicatriz radial com atipia. Para as hiperplasias ductais atípicas, ela é uma alternativa para casos selecionados. E para o papiloma sem atipia, ela não é considerada atualmente uma alternativa segura. O rastreamento mamográfico levou a uma redução média do tamanho dos tumores, e ao longo dos anos, essa redução média é associada a uma redução da terapia local. O tamanho médio do tumor num programa de rastreamento dentro do BR-VAE deve ser 14 milímetros. E o interessante é notar que a maioria desses tumores tendem a ser luminais e com um bom prognóstico. A omissão da cirurgia axilar, ela abre as portas do tratamento percutâneo do câncer de mama, uma vez que não faz sentido tratar o câncer de mama percutâneo, mas fazer a cirurgia da axila. Com o advento do sound, e agora a gente está chegando próximo dos dados do INSEMA, a gente percebe que é seguro para tumores com menos de 20 milímetros luminais não realizar o acesso axilar, a abordagem da axila, principalmente na pós-menopausa. A melhora do tratamento sistêmico também tem um efeito direto no tratamento local. Quanto melhor é o tratamento sistêmico, menor o impacto do tratamento local na sobrevida. Tem a questão da medicina de precisão, como a gente percebe, em 1970, a mastectomia era o tratamento padrão para o carcinoma in situ, para o carcinoma invasor e para o carcinoma localmente avançado. Hoje, a setorectomia mais radioterapia é o tratamento padrão para o carcinoma in situ, carcinoma luminal e o carcinoma pós-quetenel. Então, assim, nós estamos fazendo como a gente fazia em 1970, usando a mesma coisa para um monte de doenças diferentes. Então, está na hora de individualizar isso. Nossa história começa a partir de 2016, nós fazemos biópsia a vácuo desde 2008, mas a partir de 2016 a gente percebe um aumento na incidência de ausência de tumor residual pós-biópsia a vácuo. Resolvemos estudar isso e percebemos que a ausência de tumor residual tem uma relação direta com o volume que você retira, então especificamente com a biópsia a vácuo estendida, com o grau tumoral, que são os graus 1 e 2, tem maior chance de ressecção completa, e também com o tamanho tumoral menor que 10 milímetros. Existe hoje um estudo multicêntrico europeu que avalia a capacidade da biópsia a vácuo em fazer a ressecção completa de tumores e confere isso com o padrão ouro, que é a cirurgia, é o mini-VAB. E existe também um estudo randomizado controlado, que esse sim é para mudança de prática, estudo randomizado controlado, nível de evidência 3, que randomiza as pacientes entre incisão assistida a vácuo e cirurgia para pacientes de bom prognóstico, carcinomas invasores, luminais, de baixo grau, com axila negativa. Chama Small Trial. O Small Trial decolou, está recrutando muito rapidamente, como vocês podem ver no gráfico, já passou aí de 500 pacientes, ou aproximadamente 500 pacientes, e realmente vai chegar no seu alvo de recrutamento em 2025. Mas tem uma crítica em relação à incisão assistida a vácuo. Não dá para avaliar a margem. Então fica sempre a dúvida se ficou tumor residual ou não e se isso é seguro ou não. E a gente resolveu encarar esse desafio. Então, a gente começou a avaliar os casos retrospectivamente na clínica, em que a gente fazia a amostragem da cavidade cirúrgica, e a gente percebeu que a amostragem da cavidade cirúrgica era capaz de ter uma sensibilidade de 70%, uma especificidade de 66%, um valor preditivo positivo de 77%, um valor preditivo negativo de 57%. Isso numa situação em que a gente não tinha a intenção de tratar. Então, a cavidade cirúrgica negativa, o shaving das margens, conseguia, na metade dos casos, predizer que não tinha mais tumor residual, numa situação sem critério de seleção e numa situação sem intenção de tratar. Existiam algumas variáveis que relacionaram com isso, principalmente o tamanho tumoral e o peso do shaving, óbvio, a quantidade de tecido que eu tiro, e se o tumor é menor, a chance da técnica dar certo é maior. E o que foi interessante na análise de subgrupo nossa, para 25 pacientes com carcinoma puramente invasor, a avaliação das bordas cirúrgicas, o shaving da cavidade, ele mostrou 88% de especificidade e de sensibilidade, 83% de especificidade, valor preditivo positivo de 89% e um valor preditivo negativo de 83%, com uma taxa de falso negativo de 11,1%. Realmente foi uma surpresa. Então, o shaving da cavidade para tumores puramente invasivos consegue dar um bom resultado, sem intenção de tratar e sem critério de seleção. Então, a gente raciocinando sobre os nossos dados e sobre o quadro epidemiológico do câncer de mama, a gente sabe que é um objetivo reduzir o tempo de cuidado, né? O tempo de cuidado do sistema, reduzir o tempo entre o diagnóstico e o tratamento. A primeira mamografia alterada e o tratamento do câncer de mama. No Brasil, esse tempo são 45 semanas, conforme o estudo do cabelo, lá do pessoal de Campinas. Então, assim, são 10 meses entre uma mamografia alterada e o tratamento. Bom, então qual que é a nossa ideia? O VAE Breast 01, que é o tratamento e o diagnóstico, né? O diagnóstico e o tratamento do câncer de mama num tempo único, numa única intervenção. Então, o que a gente faz? Tumores, categoria 4, lesões, categoria 4B ou 4C ou categoria 5, menores que 15 milímetros, lesões únicas, são submetidas à excisão assistida a vácuo, por mamografia ultrassom, por estetexia ou ultrassom. Se dá uma lesão B3, essa paciente é acompanhada, é permitida endocrinoterapia a critério da equipe de acompanhamento. Se é carcinoma, né, ela é operada. E aí nós avaliamos se o shaving das cavidades, que é o que a gente analisa, a excisão assistida a vácuo, mais o shaving, a avaliação das bordas da cavidade, as margens, se ele é capaz de predizer na cirurgia se não tem tumor residual. Então, o endpoint primário é avaliar se a excisão assistida a vácuo mais o shaving da cavidade é um teste diagnóstico capaz de predizer a ausência de tumor residual na peça cirúrgica. O endpoint secundário seria a incidência de câncer de mama depois de uma VAE com shaving de bordas para lesões B3, as complicações e a satisfação do paciente. Essa é a técnica padrão, o conceito padrão para o shaving da cavidade. Então, o que a gente faz faz a ressecção do tumor num pensamento cirúrgico. O cirurgião sempre retira mais tumor do que ele vê, do que ele sente. Então, a gente sabe que o tumor tem uma parte microscópica que é além da nossa visão. Então, na ressecção a vácuo, você não vai tirar só até ele desaparecer imediatamente. Você vai tirar um pouco mais. E depois que você tira um pouco mais, você vai mandar esse material num frasco separado. Depois você volta naquela cavidade com sangue e tira as bordas da cavidade, que é o que nós chamamos de cavity margin shaving, que é o shaving das bordas da cavidade, e isso é a sua avaliação das margens. Então a gente desenvolveu um procedimento padrão para isso, que é uma agulha 7G. A gente usa uma agulha 7G, retira todos os fragmentos e todo o tumor, até ele não ser visto mais. Depois que a gente retira tudo, a gente faz volto naquela cavidade vazia, como vocês estão vendo no desenho. Então, eu volto na cavidade vazia, faço o shaving, resseco as bordas dessa cavidade, mando num frasco separado para o anátomo patológico, coloco o clipe e faço uma mamografia para confirmar a posição do clipe. Quem quiser acompanhar ou assistir um procedimento, é só clicar nesse QR Code que você vai entender o que é a excisão assistida a vácuo, mais o shaving de bordas. Bom, aqui a gente preparou para a nossa apresentação no EUSOB, nós já estamos com mais de 50 pacientes agora, mas naquela época a gente estava com 35, 74% dos pacientes eram câncer ou lesões B3, 40%, 14 eram lesões B3, 12 eram cânceres, todos os cânceres eram tumores luminais e apenas um com sentinela positivo. A idade média das pacientes com câncer era 63 anos, a imagem média da lesão, o tamanho médio da imagem da lesão era 10 milímetros, o tamanho patológico médio dos tumores foi 6 milímetros, o tempo médio para ressecar uma lesão, tempo médio para ressecar um câncer, apenas 20 minutos. E o número de fragmentos em média que a gente ressecou 40 fragmentos. Quando a gente olha a questão do câncer, nós tivemos 92% de procedimentos bem-sucedidos, apenas um procedimento não bem-sucedido, 83% de ressecção completa dos cânceres, apenas 2 cânceres que não foram ressecados completamente eram tumores residuais de 1,5 milímetros, um deles um ductal in situ de baixo grau. 89% de ressecção completa quando o shaving foi negativo. 100% de ressecção completa quando o shaving foi negativo e bem sucedido. E 100% de ressecção completa se você considerar que menos de 3 milímetros de lesão residual, que é o que o Minivab considera, é uma ressecção bem sucedida. Então tem boas notícias para o Hitz e para o Stewart. Se você olhar o shaving de forma global, ele tem um um valor preditivo negativo de 88%, que é muito bom no início. Mas se você olhar apenas o shaving bem sucedido, ele tem um valor preditivo negativo de 100%. Então, um caso típico que vocês veem, e vamos começar com as lesões B3, umas calcificações, 7 milímetros, que nós submetemos à incisão assistida a vácuo, 36 fragmentos, era uma hiperplasia ductal atípica, fizemos o shave, no shave já não tinha mais nada residual, nem calcificação no shave, demorou 20 minutos com hematoma grau 1, e a paciente, então, agora ela está em segmento e uma cicatriz indelével, imperceptível. Um segundo caso de exemplo, que é umas calcificações agrupadas, fizemos a incisão assistida a vácuo, 36 fragmentos, 14 gramas, sem calcificações no shave. O resultado foi um carcinoma in situ de baixo risco. O shave negativo conseguiu predizer que não tinha doença residual. Aqui a gente vê o carcinoma in situ de baixo risco. E a lumpectomia, a setorectomia, com ausência de tumor residual. Um terceiro caso, para explicar bem, um carcinoma, a gente vê aqui na mamografia contrastada, pequeno, está aqui no ultrassom, junto ao peitoral, pele, mamilo, não existe prótese, não tem contraindicação no nosso protocolo. Então, deu um carcinoma invasor, um hematoma grau 4, como vocês estão vendo, mas que 30 dias após o procedimento, no dia da cirurgia já não tinha hematoma nenhum, lembrar que os hematomas resolvem com o tempo, o shaving foi negativo e conseguiu predizer a resposta, não tinha mais doença quando a gente operou, ausência de tumor residual. Essa é a paciente no pós-operatório. Estamos avaliando as complicações, 14% de lacerações de pele, 5 casos em 35, mas todos a cicatriz é imperceptível, isso é um pontinho apenas. Criamos uma escala para avaliar os hematomas, que é um hematoma grau 0, não tem hematoma, grau 1 quando é parecido com uma biópsia, grau 2 quando é localizado, grau 3 quando ocupa um quadrante, grau 4 quando ocupa a mama toda. Mas lembrar que os hematomas da incisão assistida a vácuo, eles resolvem espontaneamente com o tempo. Quando a gente olha no tempo, os procedimentos a vácuo e a quantidade de ressecção completa, a gente percebe nitidamente que adotar a etapa da avaliação de bordas de cavidade aumenta a taxa de ressecção. Então, isso fica bastante claro. E muitas vezes a gente escuta que a cirurgia da mama é um procedimento com baixa morbidade e que não justifica omitir. E eu fico me pensando até que ponto isso é um certo grau de machismo estrutural. Bom, não cabe lembrar de um grande cirurgião americano, Blackhead, que ele fala o seguinte: no mundo da oncologia cirúrgica, a biologia é o rei, os critérios de seleção a rainha e a manobra técnica apenas o príncipe. Então, você me pergunta, é possível evitar a cirurgia da mama para o câncer de mama? Eu vou responder como se fala na minha cidade, aqui na minha terra natal, na maior obra, talvez, da literatura brasileira. Eu quase que não sei de nada, mas desconfio de muita coisa. Então, as conclusões é que o descalonamento do câncer de mama está indo rápido e os métodos percutâneos estão na fronteira. A incisão assistida a vácuo para lesões B3 tem evitado muitas cirurgias e tem mais a ser desenvolvido. A incisão assistida a vácuo para pequenos tumores de mama é factível. É um amplo campo de conhecimento, um novo campo de conhecimento a ser desenvolvido, imagem, técnica padrão, critério de seleção, patologia, e pode evitar muitos tratamentos e reduzir bastante o overdiagnóstico, o overtreatment, o supertratamento. Existe uma urgência, uma grande necessidade de treinar profissionais em técnicas minimamente invasivas cirúrgicas, não em biópsias. Então, o procedimento assistido a vácuo a técnica cirúrgica é algo para pessoas que vivem em dois mundos. O cirurgião tem que aprender técnicas de imagem com o radiologista. Ele precisa ser tão assertivo quanto o radiologista. E o radiologista tem que ser tão amplo, seguro, entender das complicações e como tratar as complicações como o cirurgião. Então, nós precisamos treinar habilidades do cirurgião, treinar habilidades do radiologista para desenvolver os métodos percutâneos. Agradecer a toda a equipe que está sempre envolvida nos nossos estudos do Breastmit Collaborative Research Group. Lembrar que, no final, tudo se trata de amor, né? Amor ao próximo. E a nossa equipe, que está aí com a cara, vocês estão vendo, alegre, né? Porque a gente fica forçando todo mundo a estudar e se aprimorar. E lembrar do sertão, né? E das veredas de Minas Gerais. Muito obrigado.
Parabéns a todos os apresentadores e, de forma especial, meu cumprimento ao Dr. Henrique Lima Couto por sua persistência nos estudos aqui na América Latina, em especial aqui no Brasil, e isso nos orgulha muito, a todos nós mastologistas aqui de Minas Gerais, tá, Henrique? Nós teremos agora um debate e temos aqui a doutora Maria Julia Calas. Ela é presidente da Sociedade Brasileira de Mastologia na Regional Rio de Janeiro, membro do Departamento de Imaginologia Mamária da FEBRASGO e é doutora em Radiologia Mamária pela UERJ. Temos também a doutora Daina Ferraz. Ela é graduada pela Universidade Federal de Minas Gerais, é oncologista na Clínica Cetus, Hospital Unimed, Hospital Semper e especialista em oncogeriatria pelo Hospital Sírio-Libanês. Teremos também a doutora Nilceana Freitas, ela é radio-oncologista no Hospital do Câncer Araújo Jorge, Sebron, Oncoclínicas e IMO em Goiânia. É doutora pela UFG e membro da diretoria da Sociedade Brasileira de Radioterapia. Temos também o prazer de receber aqui também a Maria Luiza de Oliveira, que é presidente voluntária do Grupo Pérolas de Minas. Ela é administradora, é palestrante e Desde já, Maria Luiza, recebo os meus parabéns pelos 10 anos de fundação do Grupo Pérolas de Minas. Então, eu dou a palavra, então, à doutora Maria Julia Calas, para suas considerações.
Boa tarde a todos, obrigada pelo convite, Henrique, a toda a comissão. Parabéns pelas excelentes apresentações. Claro que muita coisa muito bacana, muito nova, algumas coisas nos trazem algumas dúvidas, né, questionamentos, mas assim, realmente parabenizar a todos. Fiz algumas anotações aqui, que quero ser breve. Bom, com relação à crioablação, nós tivemos a oportunidade de fazer aqui 3 procedimentos no Rio de Janeiro. É interessante, mas temos uma questão aqui muito importante, que é o custo, né? O custo do procedimento em si, realmente, ele é assim, fora de uma realidade brasileira. Eu não sei como seria isso em outros países, né? Se isso realmente é uma coisa um pouco mais acessível, né? Porque aqui eu acho que realmente o que impacta é o custo disso, mas eu acho que vem com uma importância muito grande para uma possibilidade de um tratamento. Com relação à apresentação dos pacientes participando, eu acho isso fundamental. Eu acho que hoje em dia um tratamento, uma investigação diagnóstica, um procedimento cirúrgico, a indicação de um procedimento percutâneo, de uma cirurgia, de um tratamento a seguir, eu acho que a participação do paciente ela é fundamental. E eu acho que para o paciente poder participar, poder aderir a esse tratamento, nós temos que focar no letramento. Ou seja, é informação com comunicação. Não adianta só informar e a gente não se comunicar. Então, acho que estamos no momento, acho que a palavra do momento é essa. Então, parabenizo aí pelo trabalho apresentado. Eu acho que realmente é o momento, mas acredito que Maria Luiza vai poder falar mais sobre isso, mas realmente foi muito importante se trazer a questão do paciente como foco mesmo dessa situação. Henrique, parabéns pela escolha aí da palestrante e o assunto abordado. Com relação aos tratamentos, seja com crioablação e com a VAE também, eu gostaria de saber se sempre há indicação da colocação do clipe. Por exemplo, na crioablação, no caso de lesões benignas, após um procedimento, é indicado o clipe, sabendo mesmo que é uma indicação para uma lesão benigna, a remoção de uma lesão benigna. Henrique, com relação à VAE, podemos ter equimoses, hematomas grandes na pele, mas não necessariamente hematomas, né, volumosos no interior da mama. No caso de um hematoma volumoso, esse clipe é colocado neste momento, você tem a porcentagem de migração desse clipe, a dificuldade técnica que você possa ter tido após esse procedimento. E gostaria de saber, Henrique, porque eu vi na aula da radioterapia, que eu não vou nem ter a coragem de comentar, porque temos a melhor mulher aí que trabalha com radioterapia aqui no Brasil, que é a Nilceana, ela vai fazer suas considerações, mas com relação ao procedimento em si, quando você diz que é uma lesão única, né? Como que você avaliou essa lesão única? Essas pacientes que foram para a VAE, todas elas foram submetidas à ressonância prévia, porque no trabalho apresentado pela radioterapia, essa ressonância prévia foi importantíssima, e isso bate às vezes de frente com alguns autores, alguns trabalhos que a gente sabe que essa indicação fica aí conflitante e controversa. Então, eu acho que eram essas minhas colocações. Muitíssimo obrigada.
Boa tarde a todos, agradeço as perguntas, mas eu vou deixar o Dr. Bruce Mann começar falando sobre o seu trial e os nossos convidados, a Mhairi Mactier falar também sobre o que ela pensa, e depois eu participo.
Tá ok.
Mhairi?
Doutora Mhairi Mactier, ela pode repetir para ela a questão dessa visão entre crioablação e cisão assistida a vácuo, Maria Júlia? Doutora Mactier, você
Sim.
nos ouve? Tá com a tradução simultânea?
Posso falar? Sim, posso. Posso falar. Posso perguntar de novo?
Doutora Mactier, are you
Yeah, I can
listening to
hear
us?
you. I just didn't quite catch what the question was.
É para eu
Vai lá,
repetir a pergunta, gente?
Sim, sim.
Para ela e para o Bruce Mann.
Tá,
Yeah,
sim,
I'm listening
claro.
to
Não,
Portuguese.
com relação à crioblação, nós temos uma situação muito delicada aqui no Brasil com relação ao custo, né? É um custo realmente elevado. E se diante de uma lesão benigna, sabidamente benigna, que vai para o tratamento com crioablação, vocês de costume colocam o clipe, há uma marcação dessa área após o procedimento?
Okay, so where I work just now, we don't actually routinely perform cryoablation, so I don't know what would be the practice. And I think in answer to your question about the cost of it, all of this evidence and this good evidence that's come out of the US and this recent trial, the Thermac trial, which has showed that patients like this procedure, patients accept it. There now needs to be a cost analysis, and now that we know that patients will accept this treatment, I guess it will, and it's got good outcomes, it will then become embedded into practice and see what happens. But at the moment, it's not routinely practiced where I work.
Tá, ok. Thank you. Tinha colocado a relação da radioterapia, mas era só realmente elogiar, não vou entrar em detalhes na radioterapia, só que realmente vi como a posição da ressonância magnética prévia, né, aos estudos foi importante, e que aqui existe ainda muita literatura e muita controvérsia com relação à ressonância pré-tratamento, né? Mas foi só apenas um comentário, né? Nada, sem perguntas, digamos assim.
Obrigado, Maria Júlia. Com a palavra, então, a doutora Daina, para as suas considerações.
Primeiramente, gostaria de parabenizar o Henrique pela excelente aula, por todos os palestrantes que fizeram excelentes aulas, alto nível. E eu gostaria de perguntar para o Bruce a respeito do prospect. Já existem dados do CalGB 9343 e do Prime 2, que falam que é seguro você omitir a radioterapia em pacientes acima de 70 anos. E aí eu queria saber se com os dados do prospect, se a gente pode considerar a omissão da radioterapia nos pacientes acima de 50 anos, que foram os pacientes que foram incluídos no prospect, e abaixo de 65, ou se vai ser necessário esperar terminar a análise final em 2026. Ok. E vai mudar um paradigma, né? Provável. Tá, joia. Obrigada.
Dr.
Professor
Bruce?
Yeah, I'm only hearing Portuguese.
Oh, there is a translation button at the bottom.
Oh, sorry,
Dr.
Yeah.
Daina is asking you about Prime 2 and other trials that
Yes.
shows evidence that we don't need radiotherapy over 70 years. So it's a kind of why doing RMA in these patients since we don't need it in other trials.
I see. my answer to that is all of those trials show that the local recurrence rate at 10 years has been about 10% in the absence of radiation, but more like 2% with radiation. And our data suggests that in all groups, about 10% of patients have an additional detectable area of cancer or DCIS. Now, if in a particular patient that does not matter, then it's fine not to do it and accept a 10% rate. But many patients, for many patients, they would prefer to minimize their rate of local recurrence, and that is an argument to do it. The other point, and this is looking to the future, is that our rate of distant recurrence was minimal. So in our paper, there has not been a single distant metastasis in the first 5 years, and that raises the possibility of safe de-escalation of systemic therapy. And all of the PRIME and IDEA and LUMINA, all of those patients were recommended endocrine therapy. And it would be reasonable to say, well, the rate of recurrence is low, they don't need it, and many of us do that. But I think by searching for and treating additional disease, we can be far more confident about de-escalation of systemic therapy. So my answer is patients will do fine without, but our data, and I think it's intuitive, but our data support it, that finding and treating all of the disease that exists is better treatment. And importantly, it's not only those who are younger or with lobular or with low mammographic density who have identifiable additional disease. So, yeah, we don't have to do it, but I do think it's these data, and if it is needs further follow-up and further trials, but I think we will move to a situation that very early breast cancer is treated like colon cancer or melanoma. You find everything, you cut it out, and then your patient does not have to worry about that episode of disease. There's my long answer, but sure, you don't have to.
Obrigado. Vou chamar agora para suas considerações a doutora Nilceana Freitas. Temos apenas 5 minutos para finalizar aqui.
Olá, gente, é um prazer imenso estar aqui com todos vocês. Parabenizo ao Henrique pela brilhante iniciativa do Breastmit e por estar aqui mais um ano com vocês. É um prazer imenso. Bom, nós tivemos grandes apresentações hoje e todos com proposta do descalonamento do tratamento em pacientes com tumores iniciais. O que fica como observação é que, tanto na proposta quanto a crioterapia, quanto a biópsia a vácuo assistida, ambos fazem a proposta de uma excisão cirúrgica e a ideia é prosseguir com o tratamento da radioterapia na sequência. Até então, a gente não tem essa avaliação da omissão da rádio, mas o questionamento que a gente faz, até que haja um estudo prospectivo, randomizado, é o quão importante é uma avaliação da axila. Porque hoje nós temos a proposta de se descalonar a radioterapia, diminuindo o número de sessões, então a gente já consegue fazer essa radioterapia em apenas uma única semana, em 5 sessões, ou inclusive com a proposta de fazer a radioterapia intraoperatória numa sessão única no momento da cirurgia, que certamente também traz uma melhora de qualidade de vida para essas mulheres. E Quando você deixa de ter uma avaliação da axila com a proposta da crioterapia ou da biópsia a vácuo, a preocupação que nós temos é o quanto eu vou estar também aumentando essa radioterapia, fazendo uma radioterapia de mama toda, sendo que talvez eu pudesse fazer um descolamento com radioterapia parcial. Então, acho que isso vale como um questionamento, e é importante que nós temos aqui a presença de uma representante de pacientes, a Maria Luiza está aqui, e a questão é o quanto que a paciente vai se sentir confortável em, de fato, se omitir um tratamento. E lembrando que, nessa omissão do tratamento de radioterapia, ela precisa também aceitar fazer o tratamento de hormonioterapia durante um longo tempo. Em termos de efeitos colaterais, a pergunta que a gente se questiona, o que vai ser aceitável para a paciente? É deixar de fazer essa radioterapia, que certamente talvez pode não ter impacto em sobrevida global, mas é aceitar um risco de recidiva de 1% ao ano ao longo dos mais de 10 anos que certamente essa paciente vai ter, mas tomar o hormônio e sofrer as consequências dos efeitos colaterais com a hormonioterapia. Então, essa é a primeira pergunta que a gente tem que fazer, e conforme a Maria Julia mesmo acabou de colocar, o que mais importa nesse momento é o que a paciente quer para ela, quais os efeitos e o que ela quer da vida dela daí em diante. Então, é importante a gente esclarecer para as pacientes quanto à omissão de qualquer tratamento tradicional ao longo do tratamento do câncer de mama inicial. E um questionamento aqui para o Dr. Bruce, Professor Bruce Mann, com o estudo do Prospect Trial, o senhor incluiu apenas pacientes com câncer de mama invasor. E eu entendi que foram todas as pacientes, menos as pacientes triplo negativo. A primeira pergunta: qual foi a incidência de inclusão de pacientes que eram HER2 puro dentro do seu trabalho? E no protocolo daquelas pacientes que fizeram a radioterapia, se houve alguma dessas pacientes que fizeram radioterapia parcial de mama, para a gente ter uma comparação, ou se todas fizeram radioterapia total da mama? Essa é a minha pergunta para o Dr. Bruce.
Again, I'll need a translation briefly. I couldn't find the translation.
Okay, Dr. Bruce, Dr. Nilceana, could you ask him in English? And after that, Maria Luiza.
How many patients, Professor Bruce, you have in your trial with HER2, only HER2 positive?
Yeah, very few. Only about in the whole cohort, there were about 12, and in the group who had omission of radiation in prospect was only 4, so it's very small. And so mostly they were luminal cancers, but both luminal A and B. In prospective, in our follow-up study, we are keeping HER2 positive patients eligible, and we're going to analyze them separately because they are higher risk. But we note that BR-008, the HERO study in the United States, is looking at a very similar group, a randomized trial of emission of radiation or not. So we're confident that it will apply, but I must say my view is for HER2 positive cancers, they are a group where the systemic therapy is key, and therefore what my belief is, yet to be proven, is that T1N0 HER2 positive patients, so long as they receive appropriate systemic therapy, the risk of local recurrence without radiation will be minimal. But prospect, while they were eligible, it really does not inform management of that group. The numbers were far too small. Similarly, for grade 3 cancers, they were eligible, will remain eligible, but the numbers were quite small. I think it was only 5% of the 200, so about 10 were grade 3. And again, our view is that in prospective, we will require those patients to receive systemic therapy on the basis that surgery alone is unlikely to be sufficient for the T1N0 grade 3 cancer.
Okay, thank you, Dr. Bruce. And the last question is about the group on the radiation therapy.
Yes.
There is some patients that are doing partial breast cancer,
Yes.
partial breast radiation, or
yes.
Yes?
Well, during this time, partial breast was not widespread. The last patient went on study in 2018, and we did not specify the radiation. One of the interesting things in our next study is any radiation will be acceptable. We would expect that most of these patients would get 5-fraction partial breast. And one of the questions is, what is the short, medium, and longer term quality of life after those treatments? And this will be uniquely set up, but that comparing the quality of life outcomes for those receiving no radiation versus the 5-fraction partial breast, we will be able to inform that. And it will be interesting to see. It is clearly less toxic than full radiation. How toxic, what the impact on quality of life compared to no radiation is certainly an unanswered question so far.
Thank you.
Ok, muito obrigado. Passo a palavra à minha amiga Maria Luiza de Oliveira, que entre nós, entre as garotas que ela dá assistência, é conhecida como Malu. Malu, a palavra é sua.
Obrigada. Primeiro quero agradecer o convite. Sinto-me lisonjeada de estar aqui com profissionais preparados que estudam para nos levar qualidade de vida. No meu primeiro momento, ouvindo vocês falando, eu fiquei pensando, eu não quero que seja omitido nada de mim. E acredito que as mulheres não querem que seja omitido nada delas. É muito importante para a gente, como paciente, saber o que está sendo feito, o que está sendo proposto. E isso eu quis na minha vida, apesar de ter tido câncer de mama muito jovem, com 27 anos, e isso passaram 3 décadas, sinto-me lisonjeada de ainda estar aqui e vejo como uma missão acompanhar mulheres que recebem o diagnóstico. Eu, para mim, não quero que me omita nada, eu quero escolher aquilo que vai ser bom em longo prazo, que eu não me vi e nem me vejo vivendo só 10 anos pós-tratamento. Eu não vivi só 10 anos, eu estou vivendo 30 anos mais. Então, assim, eu quero ter perspectiva de vida. O que tem que pode ser me falado, que eu posso fazer para eu viver mais? Acho maravilhosas as inovações propostas, mas eu também me preocupo muito com o que nós estamos vivendo hoje, qual é a nossa realidade hoje. E preocupo quando que as inovações vão chegar até as nossas pacientes. Quando que um convênio médico vai dar abertura, vai dar abertura para que essas novas técnicas sejam implementadas? Nem se fala o SUS, o nosso Sistema Único de Saúde. Então, eu me preocupo a ponto de, assim, quando isso vai chegar? Quando eu posso esperar? O tratamento não é igualitário. E participando, a gente vê, cada vez que eu participo mais de um evento médico, eu vejo que nós temos 3 frentes de trabalho. Quem pode mais ou menos, e quem não pode de jeito nenhum. Os tratamentos serão completamente diferentes. E eu penso nessas que não têm acesso. É maravilhoso a gente ver o que está sendo proposto, as inovações, mas quando elas vão chegar para mim? Quando eu vou poder usufruir disso tudo? Então, eu acho assim que a gente precisa ser consultada, não omitam informação para suas pacientes. E uma coisa eu falo, a paciente tem consciência, ela conversa, ela sabe da notícia dela, então resolva isso com ela, nunca com o marido, nunca com o filho, não, resolva com a paciente. Ela é dona da sua vida e é ela que tem que responder. Obrigada.
Obrigado, Malu. Eu vou, então, encerrar essa sessão e agradecendo a todos pela participação. Muito obrigado e uma boa tarde a todos.